Okay, welcome back. I hope you enjoyed short break. We'll start the second part of today's soft tissue seminar, and it's great pleasure to introduce another great speaker today. It's Dr. Kim Thway, who will give two important, interesting talks. The first one is about fatty tumors, and the second talk is about the tumors of uncertain or differentiation.
So thank you very much, Dr. Samir. Hi, everyone. So just to say thank you very much, you and Dr. Farouk and the team in Bosnia, and also IAP, Dr. Kalonje, Prof. Nicholson and the team for very kindly inviting Prof and me to speak. Hi, everyone. So in this presentation, we'll talk about updates in adipocytic neoplasms. And so adipocytic tumours represent the commonest mesenchymal tumours, and they are, as we know, a clinically, biologically, and pathologically diverse group of tumours. There is an extremely wide histologic spectrum and frequent morphologic overlap, including between benign and malignant tumours. And there's considerable differences in prognosis and management between morphologically overlapping neoplasms, even between morphologically overlapping malignant adipocytic neoplasms. So it's important that we can discern and differentiate different adipocytic neoplasms as best as we can using standard morphology and immunohistochemistry. So this is the current WHO classification for adipocytic tumours. The 2020 classification, we have benign on the left and malignant on the right. And in red, these are the two new entities. Atypical spindle cell pleomorphic lipomatous tumour, a very broad and quite challenging to understand group of benign neoplasms that we'll discuss later, and a new malignant entity, myxoid pleomorphic liposarcoma. So, of course, we can split adipocytic neoplasms into obvious benign and malignant. So, lipoma, a very clear-cut lipoma on the left, shows no discernible atypia or mitotic activity or necrosis, in contrast to a high-grade liposarcoma on the right. And we have very prominent pleomorphic lipoblasts. So, one of our colleagues was asking Prof, how do we spot a lipoblast? We can see extremely indented hyperchromatic nuclei and optically clear cytoplasm. There is no substance in the cytoplasm. And note the very prominent indented nuclei. However, adipocytic tumours have an extremely wide spectrum of adipocytic differentiation with variable amounts of adipose tissue, lipoblastic differentiation, and a very wide spectrum of atypia. And we can see atypia even in benign neoplasms. So let's first discuss the range of fatty tumours without atypia. And of course, the vast majority of these are benign, but let's also not forget that malignant adipocytic tumours can show no atypia. So myxoid liposarcoma classically is a translocation sarcoma with a balanced translocation and shows no discernible atypia, very evenly spaced, bland, ovoid nuclei. When we look at fatty tumours with atypia, let's also remember that benign tumours can show variable atypia. These are dysplastic lipoma, spindle cell and pleomorphic lipoma, and this new entity of atypical spindle cell pleomorphic lipomatous tumour. So some words on benign adipocytic neoplasms. And of course, we are just talking about updates in adipocytic tumours. And what we'll focus on are new entities, new genetic events, and the spectrum of morphologies and things that can trip us up and catch us out. So new morphologic variants as well. Starting with lipomas, these are the commonest adult mesenchymal tumours, and they typically resemble normal-looking fat. Frequently, there is some anisocytosis, so there is variation in size of adipocytes. Frequently, we're told that variation in size of adipocytes is a criterion for well-differentiated liposarcoma. But we don't find that a useful factor because many benign adipocytic tumours can show variable change in size of adipocytic cells. So anisocytosis is not a useful criterion of benign or malignant. Lipomas typically have no atypia or no mitoses. And these are, of course, MDM2 negative, as are most lipomatous neoplasms. The only adipocytic tumours with MDM2 amplification are well-differentiated liposarcoma / atypical lipomatous tumour and dedifferentiated liposarcoma. So all other adipocytic entities are negative for MDM2 amplification. Lipomas are instead associated with various karyotypic abnormalities, so structural or numerical rearrangements involving 12q and involving HMGA2. They can also involve 6p chromosomal area involving HMGA1 gene, and about 15% of these can show 13q deletions. So 13q deletions are a characteristic of the spindle cell lipoma family. But in lipomas, where there are 13q deletions, typically these do not affect the RB1 locus. So the first benign adipocytic tumour we'll discuss is dysplastic lipoma. And this is a recently proposed lipoma subtype, slightly controversial subtype, which hasn't been fully accepted yet, and it's not a subentity in the current WHO classification scheme. But it's important that we know about it because it's a lipoma with definite atypia, and therefore the main factor is that we may overcall it as atypical lipomatous tumour, well-differentiated liposarcoma. So these are relatively rare lipomas that occur in middle-aged patients, and they are typically subcutaneous. Deeper involvement, so skeletal muscle involvement, is rare, and they typically occur in middle-aged males in the posterior neck, upper back, and shoulders. So that's 85% of them, so which is the same anatomic distribution as the typical distribution of spindle cell lipoma. These can occur at other sites, but lower extremities are rare. So they can occur on arms and the trunk, but they're rare in the legs. These can be multiple and are typically small tumours. So histologically, they're defined by extremely variable adipocytic size. So we can see the very marked difference in size of these mature adipocytes. And let's remember that variation in adipocytic size is not a criterion for atypia or malignancy. It can occur in a variety of benign lipomas. Also characteristic is single cell fat necrosis, and there is scattered focal nuclear atypia. So we can see at relatively low power that there are scattered adipocytes that show mild to moderate typically, and sometimes quite severe nuclear atypia with coarsening of the chromatin and Lockhern type change. And we can therefore confuse these for atypical lipomatous tumour, well-differentiated liposarcoma. Genetically, these have been frequently associated to show loss of RB1, total or partial, and also overexpression of P53. These lack MDM2 amplification with FISH. Some more views here. We can see a prominent variation in size of adipocytes, and we can see scattered cells, scattered adipocytes with a variety of nuclear atypia. Here, moderate to quite severe in areas with chromatin coarsening. Immunohistochemistry is not helpful. There may be variable CD34 in the surrounding fibrous areas, so variable fibrous areas, but not marked septation. There is essentially absence of MDM2 expression by immunohistochemistry. P53 often stains the most atypical cells, and authors have shown total RB loss in about 2/3 of cases and partial loss of RB immuno in the remainder. So the principal differential diagnosis is of lipoma with fat necrosis and fat-rich spindle cell lipoma, and with well-differentiated liposarcoma. So of course, the differential diagnoses of lipomas are not significant because everything is benign, but we want to know how do we discern these from ALT/well-differentiated liposarcoma. This is lipoma with fat necrosis. And what we can observe is that, again, there is anisocytosis, so there is variation in size of adipocytic nuclei, but we can see that the histiocytic nuclei are much less hyperchromatic. These are composed of typical histiocytic cells, and we can see the nuclei here. Very bland histiocytic nuclei with vesicular chromatin, small nucleoli, and there is likely amphiphilic substance in the cytoplasm of the cells, in contrast to adipocytes, which are optically clear. A lot of the time when we have very florid fat necrosis and the appearances are very busy, we can think this looks atypical. But if we look more carefully at the nuclei, we can appreciate the very bland looking histiocytic nuclei. And these may be plump, but we never see actual atypia. Next differential diagnosis is fat-rich spindle cell lipoma. So as we know, spindle cell lipoma can have a variable proportion of spindle cells, so bland spindle cells, invariably collagenous or myxocollagenous stroma with ropey collagen fibers, and small numbers of mast cells with variable amounts of mature fat. And sometimes the mature fat really predominates, but if you look carefully, there will be at least small areas where the typical morphology of spindle cell lipoma is present. And then finally, the most important differential diagnosis for dysplastic lipoma is, of course, atypical lipomatous tumor / well-differentiated liposarcoma. So just to clarify that ALT and well-differentiated liposarcoma refer to the same histologic entity. They are clinical terms assigned to tumors that occur at different sites and therefore have different prognoses. So atypical lipomatous tumor occurs in superficial, essentially surgically amenable sites, while well-differentiated liposarcoma is the same histologic neoplasm but occurs in deeper sites which are harder to excise fully. So we can see it very typical. So remember this typical morphology of well-differentiated liposarcoma, which comprises sheets of adipocytes of mature type with variable but essentially prominent intersection by relatively sparsely cellular collagenous fibrous septa. And in this fibrous septa, we can see at low power scattered atypia. So this is what Prof has always taught us, training under him. You can see the atypia in the septa, even at low power. And we can appreciate that there are scattered cells in the fibrous septa, which have hyperchromatic spindle and ovoid nuclei. On the right, we can again see another example, and this is more subtle, but there is variable septation and there are occasional hyperchromatic, moderately atypical spindle cells intermingled. Two further examples, and again, we can appreciate this prominent fibrous septation with intermingled, moderately to sometimes quite markedly atypical hyperchromatic spindle cells. Going back to dysplastic lipoma, in contrast, which has quite a busy picture because there can be variables surrounding fibrosis and some inflammation, but the atypia is seen scattered within adipocytes. So atypia within the adipocytic population rather than in the fibrous septa. So the next entity we'll quickly talk about, just because it's rare and we may be really confused when we come across it, so just to know what it looks like, is chondroid lipoma. This is a benign adipocytic tumor composed of lipoblasts that intermingle with mature adipocytes in a mixohyaline chondroid-like matrix. And something we need to remember when we're trying to diagnose adipocytic tumors is that there are typical features, but for example, a spindle cell component or a stromal component, an adipocytic component, a lipoblast component, but they can all vary in the amount of each component. And therefore, we need to be aware of the morphologic spectrum of each. So chondrolipoma occurs predominantly in women, adult women, and these are typically deep-seated tumours in the deep subcutis or the skeletal muscles. They occur on the limbs and trunk, with a significant minority occurring in the head and neck, including the oral cavity, for example, the tongue. And these can reach relatively large sizes when in extremities. And these are composed of variable proportions of mature fat with vacuolated cells, so lipoblasts, disposed in sheets, cords, and nests, occasionally giant cells. And in this variable eosinophilic myxohyaline stroma with variable thrombi, calcium, and fibrosis. Because of its adipocytic differentiation, there can be variable S100 protein expression, variable CD68 expression, and something that can confuse us, variable keratin expression. And so just very briefly, these are circumscribed neoplasms, and this is a classical picture of a tumor with this very prominent hyaline type or myxohyaline stroma in variable proportions. Sometimes the adipocytic component is very prominent or the lipoblastic component, but here the adipocytes and the lipoblast are relatively scattered, and we can see on the right these scattered plump adipocytes with non-atypical but plump liploblasts. And then we can see this very prominent hyaline stroma, eosinophilic stroma, with again very plump lipoblastic component. No atypia as such, not associated with significant mitotic activity or necrosis, and variable sheets of adipocytes. These are associated with a specific gene fusion, C11orf95 and MRTFB. The main thing is that we know this entity exists, we're aware of the specific morphology, and that we don't confuse it with myxoid liposarcoma, which also frequently occurs deeply in extremities, but we can appreciate that myxoid liposarcoma has a different morphology of discernibly myxoid stroma, unlike the very hyalinized and fibrotic stroma in chondroid lipoma. Myxoid lipoma also has only scattered and small liploblasts. Chondroid lipoma has a greater quantity of plump liploblasts and has a general eosinophilic quality to it. So another entity to talk about, just updates on this entity, is lipoblastoma. And this is a tumor that can confuse us, most of us who are not pediatric pathologists, because they occur in a specific pediatric population, and therefore when we come across them in the diagnostic setting, we can be confused and think that they're myxoid liposarcoma or even well-differentiated liposarcoma. So this is just in case we come across them and we can appreciate the salient morphologic appearances. So lipoblastoma is a benign tumor of embryonal white fat, and 90% of these tumors occur in children who are 3 years or younger. Lipoblastomatosis is the diffuse and infiltrative variant of lipoblastoma, but shows similar histologic features. And these tumors are composed first of lobules of maturing adipocytes and with variable myxoid stroma containing a primitive spindle to ovoid cell component. And these can occur at any site, chiefly the trunk and extremities, but can occur at intracavitary sites, the head and neck, the trunk, and even as primary neoplasms in viscera. These are benign tumours, although they can recur locally, particularly in the infiltrative lipoblastoma, but typically they are subcutaneous, well-demarcated tumours. So these are genetically characterised, for the most part, by rearrangements at 8q. And most of these tumours are associated with PLAG1 gene rearrangements, although less frequently with HMGA2 gene rearrangements. So these are largely characterized by PLAG1 rearrangements, and PLAG1 can fuse to a variety of partner genes, and this leads to aberrant PLAG1 overexpression. So if you have this immuno. But let's see how we can discern these morphologically. So first of all, these are lobulated looking tumours of variable amounts of maturing adipose tissue with intersection by variable thin, sparsely cellular fibrous septa. And there are also frequently lipoblast with variable maturation. There is also this myxoid component containing primitive ovoid and spindle cells with a delicate curvilinear background of thin-walled, medium-sized vessels. And the proportions of each component, so of the adipocytic component and the myxoid component with ovoid cells and vascularity, can vary. So we need to be aware that there can be adipocyte-rich variants or stromal-rich, so myxoid stromal-rich variants, and just know to look out for various proportions of each. On the left, we have classical morphology of adipocytes in sheets. These are essentially of mature type with variable lipoblasts formation, and these adipocytes in sheets and clusters are intersected by the myxoid stromal component. A close-up of the stromal component on the right, and we can see how closely this resembles myxoid liposarcoma. So if we are seeing this on core biopsy, or if we are encountering a tumor where the stromal component is rich and we do not see the adipocytic component, we can be confused for myxoid liposarcoma. And on the right, the stromal component shows myxoid cysts, and these very bland ovoid cells without discernible atypia, mitotic activity, or necrosis. And these vessels, thin-walled vessels, largely medium-sized in a curvilinear distribution. Some more examples in which the adipocytic areas are rare or lacking. And again, we can see this very prominent stromal component with the curvilinear vessels, bland ovoid and spindle cells, variably resembling myxoid liposarcoma. Picture on the left shows a tumor which has a predominant stromal component, but on the left we can see an adipocytic component, largely of mature adipocytes, but with some more immature lipoblaст-like cells. And then on the right, again, we have classical appearances, and we can note the circumscribed border. So the differential diagnosis, the principal differential diagnoses are of well-differentiated liposarcoma, myxoid liposarcoma, and the rare lipoblastomma-like tumor of the vulva. Well-differentiated liposarcoma, of course, if we remember the classical features on the left of adipocytes of mature type with variable intersection by fibrous septa, containing scattered cells with atypia discernible at low power. And let's contrast that with lipoblastoma, the adipocytic component of lipoblastoma on the right. We can see that the septa of lipoblastoma contain only bland, very delicate looking cells, and there is no discernible atypia in this neoplasm. One thing also to remember, of course, is that liposarcomas, as we mentioned, happen in a pediatric population. So 90% occur in patients who are younger than 3 years, and they're incredibly rare to occur in patients who are 10 years or older. So a young pediatric population, in contrast to well-differentiated liposarcoma, which typically occurs in middle-aged to older adults. Very rarely it can occur in the pediatric population, but liposarcomas, when they occur in young people, more typically occur in the second decade. Myxoid liposarcoma can resemble the stromal component, the myxoid stromal component of lipoblastoma, but we can see some chief differences. So myxoid liposarcoma has a very prominent myxoid background, which has a delicately amphiphilic hue, and there is a much more pronounced curvilinear network or chicken wire network of small thin-walled vessels, in contrast to the slightly larger and less marked vascular pattern of lipoblastoma. Myxoid liposarcoma also very frequently has small numbers of small lipoblasts intermingled, which is not seen in the myxoid component of lipoblastoma. Myxoid liposarcoma is, of course, also associated with DDIT3 gene rearrangements, whereas lipoblastoma is associated with PLAG1 gene rearrangements. Also, different age groups, lipoblastoma occurs in a young age group. Myxoid liposarcoma typically occurs in adults in their 20s, 30s, and 40s. It can occur in younger people, but if so, it's normally in late teens instead of a pediatric population. Finally, there is the rare lipoblasoma-like tumour of the vulva, which is an extremely rare neoplasm that occurs at this site in relatively young women with a median age of 27. So this tumour also has a very pronounced myxoid stroma, including bland ovoid and spindle cells with variable adipocytes and a prominent network of small to medium-sized thin-walled vessels. But we have to remember the clinical context that this occurs in. This is not associated with any specific genetic events. So spindle cell lipoma, moving on to updates on this entity next. So spindle cell lipoma is a completely benign neoplasm, which typically occurs in superficial sites, essentially the deep subcutis, only very rarely the muscle. And we all know that these most frequently occur in the very typical site of the posterior back, neck, and shoulder. So the shawl distribution of middle-aged to older men, so men who are age 45 or older. This can also occur at other sites, a variety of other sites, including the head and neck and the limbs. When it occurs at unusual sites, it can occur at deep sites, and it more frequently affects women who are younger. Pleomorphic and spindle cell lipoma constitute a morphologic spectrum of one disease process. So they're unified by similar genetic events. Spindle cell lipoma, as we are aware, is composed of variable distributions of mature adipocytes, bland spindle cells, and ropey collagen fibers. Pleomorphic lipoma clinically occurs in a similar distribution to spindle cell lipoma, but is much rarer. So clinically and biologically, it is the same. Genetically, it is the same, but the pleomorphism in pleomorphic lipoma is about the multinucleate. So this refers to multinucleate floret-like giant cells. We do not see atypia in the spindle cell component. The pleomorphism in pleomorphic lipoma refers to the multinucleate floret-like giant cells that are intermingled. So spindle cell lipoma, classical morphology, we are familiar with these very short ovoid cells in vague streams or patternless arrays in variable proportions. So they have short nuclei without discernible atypia, small amounts of fibrillary cytoplasm in variable myxoid or delicately collagenous stroma with variable amounts of intermingled collagen fibers, so rope-like collagen fibers, and variable adipocytic component. The adipocytic component can show variable size and so there is a degree of anisocytosis in this as well, and frequently there are small numbers of intermingled mast cells. The tumour on the right shows a much more cellular, slightly more solid appearance. Pleomorphic lipoma refers to a tumour in the same biologic group as spindle cell lipoma, but with the addition of variable multinucleate floret-like giant cells. And the pleomorphism refers to these cells rather than any frank atypia in the spindle cell component. Spindle cell lipoma is characteristically diffusely and strongly positive for CD34 and genetically is associated with loss of material at 13q, with deletion of RB1 and therefore lack of RB1 expression if you have that immuno. These do not show MDM2 amplification. Some morphologic variants. So the pseudoangiomatous type of spindle cell lipoma shows classical features of spindle cell lipoma, but with a tumour forming papilliform projections of tumour into cystic angulated spaces lined by tumour cells. Low fat or fat-free spindle cell lipoma refers to spindle cell lipoma with very small numbers of mature adipocytes or no adipocytes. And of course, this can be confusing and look like other tumours such as solitary fibrous tumour or myxoid DFSP or neurofibroma, etc., because we do not see a discernible adipocytic component, or we only see small numbers of adipocytes, which we may think represent native fat. Spindle cell lipoma can sometimes be very myxoid in appearance, and this can be really confusing, again, when there is a limited adipocytic component, and this can look like myxoid liposarcoma or myxoid DFSP. So the differential diagnosis includes myxoid liposarcoma, solitary fibrous tumour, and neurofibroma, amongst other entities. So we have an example of myxoid spindle cell lipoma on the left and myxoid liposarcoma on the right. So first thing is, of course, to always think about the clinical context. So myxoid liposarcoma occurs in young to middle-aged adults, chiefly in deep soft tissues of the extremities, sometimes the trunk, whereas spindle cell lipoma occurs typically in an older population in the shawl distribution of the back of the neck or shoulder. And we can see the differences between the two. Myxoid liposarcoma has this very homogeneous distribution of small, curvilinear, thin-walled vessels in a very discernible plexiform network, which is lacking in myxoid spindle cell lipoma. Both of them contain bland ovoid and spindle cells. Myxoid liposarcoma is also associated with small numbers, generally small numbers of small lipoblasts. Genetically, they are different, with myxoid liposarcoma showing DDIT3 gene fusions. Solitary fibrous tumour can, in some instances, be very confusing for spindle cell lipoma, because they are both composed of very bland ovoid to spindle cells and are both strongly positive for CD34. Solitary fibrous tumour typically has the morphology of more hypercellular and more sparsely cellular collagenous areas, containing only small numbers of spindle cells. The fibroblast population of solitary fibrous tumour is frequently just a little more spindled than the very classical ovoid short nuclei of spindle cell lipoma. Solitary fibrous tumour also frequently has this very pronounced HPC, so hemangioparasitic vascular pattern of angulated thin-walled vessels, which is lacking in myxoid spindle cell lipoma. And spindle cell lipoma will lack the classic NAB2 STAT6 fusion of solitary fibrous tumour. SFT is also diffusely positive in nuclei for STAT6, which is again lacking in spindle cell lipoma. Finally, neurofibroma can look like spindle cell lipoma because of its variable myxoid change and its fibrillary shredded carrot-like appearance of neural and collagen fibers. The main difference is that the fibers are shredded carrot-like and not ropey like the ones we see in spindle cell lipoma, and the cells are much more elongated. So the spindle cells have somewhat hyperchromatic nuclei and show much more elongated nuclei, in contrast to the typically ovoid short nuclei of spindle cell lipoma. Neurofibroma can show variable CD34, typically not diffuse, in contrast to spindle cell lipoma, and this also shows S100 protein strongly in most cells, in contrast to spindle cell lipoma. The various authors have noted that tumours looking very much like either spindle cell lipoma or pleomorphic lipoma can have appearances that differ somewhat from them, despite having spindle cell or pleomorphic lipoma-like morphology. And this includes clinically these tumours being infiltrative and histologically showing infiltrative borders, also showing an atypical spindle cell component and variable lipoblasts. So these very much resemble spindle cell or pleomorphic lipoma in many ways, but additionally show infiltrative borders, spindle cells with atypia, which is characteristically lacking in spindle cell and pleomorphic lipoma, and variable numbers of lipoblasts. That ties in to the entity known as spindle cell liposarcoma, which various authors have described as spindle cell liposarcoma, atypical spindle cell lipoma, and fibrosarcoma-like lipomatous neoplasm. And these have always referred to adipocytic tumours with some morphology resembling spindle cell or pleomorphic lipoma, with a variable spindle cell component showing variable atypia, and variable numbers of lipoblasts. And spindle cell liposarcoma was always a very heterogeneous group of tumours, generally of atypical lipomas or low-grade adipocytic, low-grade malignant adipocytic tumours, which did not fall into the classic morphologic patterns of any of the liposarcomas or any of the benign adipocytic tumours. So a very heterogeneous group of tumours. Occurring in adults in various sites, but frequently the extremities. These were later shown to many of them to represent variants of well-differentiated and even dedifferentiated liposarcoma, but many others of these were not absolutely classifiable. More recently, authors have defined the term atypical spindle cell pleomorphic lipomatous tumor. So this was a term that has been coined by Doctors Marino Enriquez and Dr. Fletcher, and this is now an entity in the current WHO classification. So let's try and characterize the tumours that fall into this category. So atypical spindle cell pleomorphic lipomatous tumour represents a very heterogeneous group of benign tumours. So these are all benign tumours that can variably recur. They have a recurrence rate of about 10 to 15%, but they do not metastasize. So these are all technically benign tumours. And these have variable appearances with variable proportions of spindle cells, adipocytes, and lipoblasts with variable atypia, somewhat resembling spindle cell lipoma or pleomorphic lipoma, hence the name atypical spindle cell pleomorphic lipomatous tumor, all unified by the presence of infiltrative margins and the fact that they all lack MDM2 amplification. So these are not liposarcomas, and a lot of the time, because of their variable atypia, because of the spindle cell component, we can overcall them as well-differentiated and even dedifferentiated liposarcoma. These are tumours of adults with a male preponderance, and they most frequently occur in the limbs. They can occur in intracavitary sites, so the mediastinum, the abdomen, and pelvis, but they most frequently occur in limbs. 50% are superficial, 50% are deep, and they show ill-defined margins. That's in contrast to other benign adipocytic tumours, which frequently show very defined, circumscribed margins. And they have a variably cellular spindle cell component, and we'll see examples of that later, as well as differentiated adipose tissue with variable uni or multiveculated lipoblasts. They're clinically distinct from other known benign or malignant adipocytic entities. None of them have been shown to metastasize, but there is a significant small chance of local recurrence, particularly after incomplete excision. So this is about 10 to 15%. And we need to be aware of the morphologic spectrum. So the main thing here is for us not to overcall them as well or dedifferentiated liposarcomas or another liposarcoma subtype. So the thing for us to remember is that these are infiltrative tumours, most frequently occurring in extremity sites, either deeply or superficially, with variable amounts of spindle cells, which are variably pleomorphic, and variable numbers of adipocytes and lipoblasts in a myxoid or collagenous stromal background. Immunohistochemistry doesn't help us. The immunoprofile is non-specific. So about 2/3 show variable CD34, typically not the diffuse and strong expression we see in spindle cell lipoma. About 40% show S100 protein expression, 20% show variable desmin expression, but no myogenin or MyoD1. There is essentially no expression in nuclei, or very weak expression only, of CDK4, P16 or MDM2. 2/3 of these have been shown to show RB1 loss with immunohistochemistry, and none of these show MDM2 amplification with FISH. Thing to remember is that atypical spindle cell pleomorphic lipomatous tumor is an evolving entity representing a morphologically heterogeneous group of tumors, somewhat resembling spindle or pleomorphic lipoma, but with variable atypia, lipoblastic component, and adipocytic component with infiltrative borders. So we need to have an index of suspicion for them and not overcall them as liposarcomas, because they are benign entities with a small chance of local recurrence. So variable morphologies here. So these examples are relatively hypocellular, and we can see they're present in delicately collagenous stroma. Both examples show scattered scattered multinucleate cells with floret-like nuclei. So they somewhat resemble pleomorphic lipoma, but we can also see that architecturally these do not fit with spindle cell or pleomorphic lipoma. The background spindle cells are not the classical short ovoid cells that we see in spindle cell lipoma. We don't see prominent ropey collagen. These examples show more cellularity. So on the left, we see a much greater degree of cellularity, only a small adipocytic component. And of course, this morphology can be worrying, but MDM2 is not amplified. MDM2, CDK4 and P16 immunohistochemistry will be negative. More examples here, again, somewhat resembling spindle cell lipoma, a little bit of rope-like collagen in the example on the left, but we see a spindle cell component, particularly in the tumor on the right, which shows elongated nuclei, not typical of the short ovoid nuclei in spindle cell lipoma. Challenging cases, here we see a very prominent spindle cell component with variable adipocytes and just very occasional lipoblasts. So now we will move on to liposarcoma, so updates in liposarcomas. And of course, these are malignant adipocytic neoplasms, and the conventional types in the current WHO are, as we know, well-differentiated and dedifferentiated liposarcoma, myxoid liposarcoma, pleomorphic liposarcoma, and this new entity of myxoid pleomorphic liposarcoma, which we'll come to. Liposarcomas represent the commonest soft tissue sarcomas, accounting for 20% of all malignant mesenchymal tumours. And they're predominantly tumours of adults. They very rarely occur in young people. And when they do, it's typically in the second decade rather than in the proper pediatric population. When they occur in the pediatric population, all varieties can occur other than pleomorphic liposarcoma, which is rare. Most frequently, myxoid liposarcoma occurs, followed by well and D. diff. And this new entity, a very rare entity of myxoid pleomorphic liposarcoma, which has a propensity to occur in young and pediatric females. These subtypes are essentially genetically distinct. And so the commonest subtypes are well and dedifferentiated liposarcoma. So these two together constitute the largest liposarcoma subgroup, and they represent a genetic, histologic, and behavioral spectrum of one disease. Well-differentiated liposarcoma accounts for up to 45% of all liposarcomas. And these tumours occur in middle-aged, older adults, so most frequently in the 5th to the 8th decades, most frequently in the retroperitoneum and extremities. Well-differentiated liposarcoma can also occur in paratesticular sites, mediastinum, and head and neck. So let's begin by talking about ALT/well-differentiated liposarcoma. So as we mentioned previously, these refer, so ALT and well-differentiated liposarcoma refer to histologically identical tumours, but are divided into clinical subtypes. So ALT clinically refers to WDL in surgically amenable soft tissue sites, with well-differentiated liposarcoma representing the same tumour in deep central anatomic sites and therefore requiring more radical excision, frequently with the excision of multiple organs and viscera in the retroperitoneum. These are locally aggressive tumours, but lack metastatic potential. However, they can dedifferentiate in about 10% into dedifferentiated liposarcoma. Dedifferentiated liposarcoma is much more locally aggressive with higher local recurrence rates, and of course, it has metastatic capacity. So the local recurrence rate of well-differentiated liposarcoma is between 30 to 50%, depending on the site, as we might imagine. And the site is the biggest predictor for relapse and prognosis. So we can imagine that if this is located on extremity sites where these are easy to monitor, the chance of local recurrence, or the chance of dedifferentiation, is much lower than in a site such as the retroperitoneum, abdominopelvic sites. So well-differentiated liposarcoma can dedifferentiate at any site, but there is a much higher risk of this in deep sites, particularly the retroperitoneum. In these sites, patients frequently have repeated recurrences, with death from aggressive local recurrence, or more rarely from dedifferentiation and metastasis. Dedifferentiated liposarcoma occurs most frequently in the retroperitoneum, although up to 90% occur de novo. About 10% discernibly dedifferentiate from well-differentiated liposarcoma. And this is a high-grade sarcoma, a pleomorphic high-grade sarcoma with aggressive local growth and recurrence and the potential for metastasis. However, even though it's a high-grade pleomorphic sarcoma, it tends to behave more indolently than other pleomorphic sarcomas, such as undifferentiated pleomorphic sarcoma and leiomyosarcoma. So it's still very important to be able to make an accurate diagnosis of dedifferentiated liposarcoma because of its much more indolent behavior than other pleomorphic sarcomas. Mortality is again more typically due to uncontrolled local recurrence than distant metastasis. So understanding the genetics of well-differentiated and dedifferentiated liposarcomas, these are both associated with high-level amplifications at 12q13 to 13 to 15 region. And this region contains a variety of cell cycle oncogenes, but particularly MDM2 and CDK4. And MDM2 is the main driver for tumorigenesis in the 12q amplicon. There are other genes that are amplified in this region, including HMGA2 and CPM. Dedifferentiated liposarcoma genetically varies from well-differentiated liposarcoma, still having these genetic events in the 12q13 to 15 amplicon, but having additional genetic events besides that, leading to tumor progression and more aggressive behavior. There are more frequent high-level amplifications and more total amplifications than well-differentiated liposarcoma, and typically there are further genetic changes, particularly involving genes at 1p, 3.2, and 6q23. There are a variety of targeted treatments to genetic events occurring in dedifferentiated liposarcoma, such as MDM2 and CDK4 antagonists, and therefore, of course, it's really important that we be able to accurately diagnose dedifferentiated liposarcoma and discern it from other pleomorphic sarcomas. We can see very strong and diffuse nuclear CDK4 expression in well-differentiated liposarcoma, and we can see the high-level amplification, the green dots there, of MDM2 in this tumour. Dedifferentiated and well-differentiated liposarcoma are associated with diffuse and strong nuclear CDK4, MDM2, and P16 expression. P16 is another gene that is overexpressed, closely related to CDK4 and MDM2, and overexpressed in the context of well and D. diff liposarcoma. And again, it's a useful marker in the context of a panel, in the context of a whole panel, and with CDK4 and or MDM2 to be able to distinguish dedifferentiated or well-differentiated liposarcoma. None of these are specific markers, so it's optimal to use at least two markers, and we should see diffuse and strong nuclear expression. So not focal, not weak expression. MDM2 amplification with FISH is the diagnostic gold standard for adipocytic tumours. So for differentiated adipocytic tumours, so those composed of mature type fat, it is an extremely useful diagnostic tool, even better than histology in many tumours, because there are lipoma-like well-differentiated liposarcomas, which due to sampling error or otherwise, we are not able to identify atypical nuclei. So let's remember that MDM2 FISH MDM2 FISH is not amplified. So MDM2 is not amplified in any other adipocytic tumor outside of well and dedifferentiated liposarcomas. But the presence of MDM2 amplification itself is not a specific event. It's also seen in a variety of other tumors. So the context that we use it in, the most useful contexts, are in distinguishing well-differentiated liposarcoma from lipoma and other tumors of differentiated adipocytes, and to distinguish dedifferentiated liposarcoma from other pleomorphic and spindle cell sarcomas in the retroperitoneum and abdominal cavity. So useful context, as we mentioned, to discern lipoma or other benign adipocytic tumours from well-differentiated liposarcoma, particularly useful when these tumours are deep, i.e. within skeletal muscle, whether they are large, so more than 10 centimetres, and in recurrent tumours. As we know, lipomas can occur, particularly when they have been previously incompletely excised, but sometimes lipoma-like well-differentiated liposarcoma can be really difficult to distinguish on histology. So FISH for MDM2 is useful in this context. Also useful to distinguish dedifferentiated liposarcoma from other pleomorphic sarcomas in the abdominal cavity, and also in other contexts, for example, to be able to differentiate myxoid pattern well or D-diff liposarcoma from myxoid liposarcoma, and to differentiate D-diff liposarcoma from myxoid pleomorphic liposarcoma. MDM2 amplification is a non-specific event, and it's seen in up to 40% variably in other sarcomas. So let's remember the specific contexts that are useful to us in the context of fatty tumours. MDM2 is also positive in certain rhabdomyosarcomas, myxofibrosarcomas, a proportion of undifferentiated pleomorphic sarcomas, malignant peripheral nerve sheath tumours. Some of these show low-level amplification rather than the very high-level amplification that is associated with well and D-diff liposarcoma. And MDM2 amplification is also a very helpful factor or characteristic in other sarcomas, for example, intimal sarcoma and cardiac sarcoma, in which approximately 2/3 show amplification of MDM2, and it's characteristic in paraosteal osteosarcoma. MDM2 is amplified in almost all well-differentiated liposarcomas, probably about 97 to 99%. Just a slightly fewer number of dedifferentiated liposarcomas, probably about 92 to 95%. So let's remember that MDM2 is not always amplified. There may be other alternate events, such as CDK4 amplification or other genes in that region. Morphologically, well-differentiated liposarcoma, as we've mentioned before, shows mature adipose tissue with variable fibrous septation. Usually the fibrous septa are quite thick, with variable morphology, with nuclear atypia that's discernible at low power in the fibrous septa. Lipoblasts are typically rare. That's in contrast to lipoma on the left. We can see in this lipoma that there is significant anisocytosis, so so difference in the size of the adipocytes, and that is not a useful factor for discerning benign from malignant adipocytic tumours. We can see the very prominent scattered atypia at low power for well-differentiated liposarcoma. Just a few quick words on morphologic variants. So in sclerosing well-differentiated liposarcoma, there is a very prominent, delicately collagenous stromal component, and the adipocytic component is lacking or is very limited. And of course, this can be confusing, especially on core biopsy. Inflammatory well-differentiated liposarcoma shows a variable inflammatory infiltrate, typically lymphoplasmacytic, which sometimes can be so marked as to obscure the atypical spindle cells in the background. When it's marked, it can also be confused with hematolymphoid processes such as Castleman disease or various lymphomas. A caveat here is that well-differentiated liposarcoma can sometimes show hibernoma-like morphology with lobules and sheets of multivacuolated, relatively uniform adipocytes. But let's remember that even the hibernoma-like well-differentiated liposarcomas show variable fibrous septa with interspersed variable nuclear atypia. Differential diagnosis of well-differentiated liposarcoma is lipoma with fat necrosis, and that's something that probably confuses many of us, because lipoma with fat necrosis, particularly after it's subject to chronic changes, trauma, can show a very busy, florid picture with lots of histiocytes and fibrous septation and variable inflammation. But let's remember also that the histiocytic nuclei are typically, even if they're plump, the bland ovoid nuclei with small nucleoli and a substance in the cytoplasm, in contrast to lipoblasts and in contrast to adipocytes. A caveat is with P16. P16 is strongly positive in areas of fat necrosis, so that can trip us up. We can overcall lipoma with florid fat necrosis as well-differentiated liposarcoma, but we can see how limited the distribution of P16 is, and in contrast to the diffuse and strong nuclear expression that we see in well and dedifferentiated liposarcoma. We can see another field in the same tumor, i.e. lipoma with fat necrosis, in which the P16 is almost completely absent. So moving on to dedifferentiated liposarcoma. Dedifferentiated liposarcoma is, of course, technically a non-lipogenic sarcoma. So we should not see adipocytic differentiation. And most frequently, as with other dedifferentiated tumours, there is an abrupt demarcation with the well-differentiated component, but more rarely there can be a more subtle intermingling. Dedifferentiated liposarcoma typically has the morphology of undifferentiated pleomorphic or spindle cell sarcoma. It can have variable patterns. A relatively frequent pattern, particularly in the retroperitoneum, is this myxoid change. So a myxofibrosarcoma-like pattern with a variably atypical cells in myxoid stroma, frequently with a curvilinear pattern of large vessels, looking like myxofibrosarcoma. And then even more deceptive is when there is myxoid change, but the cells are quite bland and there can be a prominent vascular network of small vessels, and dedifferentiated liposarcoma can resemble myxoid liposarcoma. It can also show various heterologous differentiation to osteoid, chondroid, smooth or skeletal muscle. One thing to remember also is that there is a rare pattern which can sometimes be focal, but even more rarely comprise the whole of the tumour, and this is low-grade pattern dedifferentiation. And in low-grade pattern dedifferentiation, the dedifferentiated component does not look like pleomorphic sarcoma, but instead resembles a bland fibroblastic or even neural neoplasm, and can resemble fibromatosis or a low-grade sarcoma. Or on the right, we can see it looks like just a very bland fibroblastic neoplasm. And the thing to remember is that we mustn't undercall it as a benign entity. And we also need to remember that that low-grade pattern dedifferentiation is still thought to have the same clinical behavior as standard dedifferentiated liposarcoma. So it does not represent more indolent disease. Homologous lipoblastic differentiation is also another rare finding in dedifferentiated liposarcoma. So we described that dedifferentiated liposarcoma is typically a non-lipogenic tumor, but rarely dedifferentiated liposarcoma can show variable adipocytic, i.e. lipoblastic differentiation scattered throughout the neoplasm, sometimes very prominent, and can look like pleomorphic liposarcoma. Instead of, in contrast to pleomorphic sarcoma, dedifferentiated liposarcoma with homologous lipoblastic differentiation shows diffuse and strong CDK4, MDM2, and P16 immunohistochemistry. It's important to be able to distinguish the two because prognostically they are different. Dedifferentiated liposarcoma is more indolent than pleomorphic liposarcoma, and of course, because the genetic background is different, pleomorphic liposarcoma is associated with complex karyotypes without recurrent genetic events, whereas dedifferentiated liposarcoma has recurrent genetic abnormalities, including amplification of MDM2, and therefore is likely to be amenable to targeted therapies. No real new updates on myxoid liposarcoma, just for us to remember this very characteristic morphology of bland ovoid cells with this prominent, evenly spaced curvilinear vascular network associated with DDIT3 rearrangements with FUS or more rarely EWSR1. But we now go to the new liposarcoma, so the new entity in the current classification, which is myxoid pleomorphic liposarcoma. And this is a liposarcoma subtype that has a wide age range, but has a propensity to occur in young patients, predominantly children and young adults, and more frequently in female patients. This has a predilection for the mediastinum, although can occur at a variety of deep soft tissue sites. But very strikingly, it seems to occur very frequently in the mediastinum in young female patients. Genetically, we still don't know much about it. Some patients have Li-Fraumeni syndrome. These are extremely aggressive tumors with a high rate of local recurrence and a high propensity for metastasis to distant sites and soft tissue sites. And these tumors are so called because they have morphology that is variably resemblant of myxoid liposarcoma and pleomorphic liposarcoma. So the main points are these show extensive myxoid stroma with a vascular pattern reminiscent of myxoid liposarcoma, but other areas with pleomorphic lipoblasts and significant atypia resembling pleomorphic liposarcoma. So let's look at examples. Here we see quite low-grade looking tumours, and we would very much think that these were myxoid liposarcomas. We can see myxoid stroma, very uniform looking ovoid and spindle cells with myxoid pools that are typical of myxoid liposarcoma. Other views here on the left, we can see prominent myxoid stroma, again with this prominent vascular network of medium-sized thin-walled vessels, very much looking like myxoid liposarcoma. Don't forget that these have a propensity to occur in the mediastinum, so thorax and mediastinum. When we look at a slightly medium power magnification, we can see that there is actually some atypia, at least mild and moderate here. And this is in contrast to myxoid liposarcoma, in which we do not see atypia because this is a translocation sarcoma with a balanced translocation. So already we can see that this is not classical of myxoid liposarcoma. And then in other areas, we see much greater cellularity, still with myxoid stroma, but we can begin to appreciate that there is much more atypia and there are scattered lipoblasts, including pleomorphic lipoblasts. And in these views, these tumors resemble pleomorphic liposarcoma. Genetically, MDM2 is not amplified, and these are not associated with specific gene rearrangements. So quite little is known about the genetic background, other than some patients have Li-Fraumeni syndrome, but these appear to have non-recurrent chromosomal aberrations, including RB1 inactivation. Some authors think that these may represent a subtype of pleomorphic liposarcoma, but because they occur in a pronounced clinical group of in a clinical group with this pronounced morphology of myxoid liposarcoma-like areas and pleomorphic liposarcoma-like areas. These are classified for now as a distinct entity. And then just to finish off with pleomorphic liposarcoma. So we know about pleomorphic liposarcoma. This has the background of undifferentiated pleomorphic liposarcoma, but shows variable numbers of pleomorphic lipoblasts. And the only thing of note in this context is that there is an epithelioid variant of pleomorphic liposarcoma, which occurs in about 25% variably. Sometimes the epithelioid variant can predominate, and in these instances, we can mistake these for various carcinomas and melanoma. This can be treacherous because the epithelioid component can show variable keratin and melanate expression. So just to know that pleomorphic liposarcoma can have an epithelioid component. And that ends the talk. Thank you very much.